The disease with 1,000 faces. Difficult to diagnose, complex, and chronic. It will strike 1 in 900 Canadians. Lupus. This autoimmune disease alters patients' lives, and if left untreated, can be fatal. At the BC Lupus Society, we provide support to people living with lupus. Because lupus is unpredictable, we strive to be dependable. Our programs include weekly support groups for patients and families in British Columbia. We make sure that educational resources and peer contacts are always available, including for patients facing a new lupus diagnosis. And every year, we help fund clinical training and medical research that benefit people with lupus. Through the BC Lupus Research Scholar Program, our goal is to advance treatments and discoveries to change the future of lupus. Our partnership with university researchers is unique in Canada and has helped understand the full impact of lupus and the effectiveness of lupus care. As part of our community, you're a valued part of annual events like our Lupus Gala and the Shed Light on Lupus Walk. These fundraising activities generate just part of the funds needed to sustain our work in patient support and medical research. With the generous support of donors like you, the BC Lupus Society will continue to be here for patients and families affected by lupus. Not only can we change tomorrow, we can brighten today. Thank you from the BC Lupus Society.
So in terms of my talk, I'll be covering what exactly CAR T-cell therapy is, its background use in cancer, as well as its investigational uses in lupus, some of its side effects, as well as the current Canadian landscape. So firstly, what is CAR T-cell therapy? So as you probably know, T cells are part of the body's natural immune system, and they're a subset of white cells that help the body to recognize pathogens, as well as to kill cancer cells, and to activate other parts of the immune system. So CAR T-cell therapy is essentially harnessing the body's natural immune system, but in enhancing it with genetic engineering. And so essentially they're creating what's called a chimeric antigen receptor, or CAR protein, on the surface of the T cells that allows these T cells to now recognize a very specific antigen. And so it becomes very directed in terms of recognizing and targeting a specific antigen to allow for vigorous immune activation. So I wanted to discuss its background in oncology and cancer, which is where its use was first found. And so there are trials in CAR T-cell therapy that date back to the 1990s to 2000, but the big breakthrough really came about in 2016, 2017. And 111 patients with diffuse large B-cell lymphoma were enrolled in a trial for CAR T-cell therapy. And patients who got the CAR T therapy had an objective response rate of 82%, which was compared to a historical control rate of 20%. And so this was very significant. And so this completely revolutionized treatment for lymphoma. And as a result, the FDA approved CAR T therapy for lymphoma and leukemia patients in 2017. And what is the process exactly of how CAR T-cell therapies are made? So firstly, we have the peripheral blood, that is the white cells that are collected via something called apheresis. And that's a process that's very similar to a blood donation. And so the blood is essentially taken and the white cells are sorted out. And then these white cells are then grown and expanded in a specific culture that allows them to proliferate. And then the CAR T-cell gene is transferred into the native T cell using a variety of different techniques. So often a lentivirus integrates into the T cell genome so that the T cell natural genome is starting to produce the CAR gene so that it becomes expressed on the cell surface. While this is happening, the patient also receives something called lymphodepletion, usually with chemotherapy, so that the patient's own white blood cells are reduced so that when the final step, the infusion of the CAR T cells is delivered into the patient's own white blood cells are lower, which allows the CAR T cells to rapidly expand in the patient's body. So how is all of this relevant to autoimmune disease? We know that B cells play an important role in autoimmune disease in diseases like lupus, rheumatoid arthritis, and myositis. And so many of these diseases have these autoantibodies that are formed from B cells, and these antibodies are often appearing long before the onset of any symptoms. However, in the past, treatment of autoimmune disease with B-cell depleting antibody medications has at times been disappointing, like rituximab in lupus nephritis. And they theorize that maybe this is because there isn't enough B-cell depletion in the tissues, or some of these long-lived memory B cells are escaping depletion by these treatments like rituximab. So what about CAR T cells in autoimmune disease? So for a long time, researchers have been trying to develop a way of resetting the immune system. But there's a lot of theoretical reasons why maybe this doesn't work. Like, for example, patients might already have organ damage, for example, lung fibrosis or kidney damage that limits reversibility of their symptoms. But there were some promising results in mouse models for CAR T therapy that was targeting B cells in autoimmune disease. And so as a result, it was thought, well, why don't we create CAR T therapy that there is able to specifically recognize CD19 antigen on B cells so that these B cells are not producing all of these antibodies and causing damage related to lupus. And just as a little bit of background in terms of CD19 antigen, so CD19 antigen is just a marker or a molecule on the surface of B cells, but it's expressed in different stages of the B cell's life. And so as you can see, CD19 is involved in the expression all the way from premature B cells to plasmablasts, which are often implicated in disease activity in lupus. And other medications like rituximab, for example, target the CD20 antigen, which are only expressed on a smaller subset of B cells. So it's theorized that with CAR T cells targeting CD19, maybe that's a better antigen because it is involved in more B cells across its lifespan. So the first human trials actually came about in 2019 when a patient from China had received CAR T cell therapy, and she had a history of lupus, but had also recently been diagnosed with stage 4 lymphoma. So she had been on chemotherapy for the lymphoma, but this was stopped because of severe side effects. So she was able to get CAR T therapy approved on the basis of her lymphoma. But in terms of her lupus response, they also found that her anti-nuclear antibody was undetectable, her complement levels had normalized, and her lupus symptoms had significantly improved. And 4 months after getting the CAR T infusion, she also had imaging done, which showed the lymphoma lesions were also absent, and she was in remission from a lymphoma perspective. So as a result of this, Dr. George Schett's group from Germany decided to also test CAR T cell therapy in a 20-year-old woman who had severe treatment-refractory lupus. She had a lot of different organs involved, including kidney problems, pericarditis or fluid around the heart, pleuritis, fluid in the lungs, rashes, kidney disease, arthritis, as well as a history of Liebman-Sachs or valve lesions in the heart. And she had gotten a lot of different medications, including steroids, Plaquenil, mycophenolate, belimumab, rituximab, all of which didn't control her symptoms. All of these treatments were stopped before the CAR T cell infusion, and only low-dose steroid was administered. So she got conditioning chemotherapy 3 to 5 days before the CAR T treatment. And they found that in terms of the lupus antibodies, like the double-stranded DNA, this completely normalized, and her complements also normalized. Her protein in the urine, which before was over 2,000 milligrams a day, had also normalized. And her Selena-SLEDAI score, which is a marker of disease activity, had dropped from 16, which is severe, to 0 by 1.5 months. And all of her medications, including steroids, were able to be successfully stopped without disease relapse. And she's now been followed for 30 months or 2.5 years. So as a result of this very promising first patient, there were 4 more patients with lupus that were enrolled into this CAR-T trial. And again, all of these patients had moderate to severe disease activity, and all of these patients had multi-organ involvement. But all of them, again, were able to achieve drug-free remission of all medications. So what about side effects, though? There is a phenomenon called cytokine release syndrome, or CRS, and this is essentially where the CAR T cells, as you can imagine, with kind of killing all of these autoreactive B cells that can result in the release of all of these inflammatory molecules called cytokines. And so that can cause symptoms like fever, headaches, joint pains, muscle pains, and rashes. In more severe cases, may also cause low blood pressure, heart failure, respiratory failure, and in very severe cases, even death. And so for leukemia lymphoma patients, the CRS is relatively common. About 40 to 90% of patients may experience this, although only 10 patients have a severe form of it. Usually, treatment is with steroids, as well as with a medication called tocilizumab, which helps downregulate these cytokines. Now, what about these lupus patients who got CAR-T therapy? So they found that of these 5 patients, they had no or only mild cytokine release syndrome. Fever, which is cytokine release syndrome grade 1, did occur in 3 of them. But overall, it seemed that it was less frequent than in patients with cancer, presumably because of much lower B cell levels in patients with lupus compared to hematologic malignancies. So the group in Germany decided to further expand CD19 CAR T cells into autoimmune disease in general, including 3 more lupus patients, so 8 total, along with 3 myositis patients and 4 scleroderma patients. And so this study was just recently published in the New England Journal of Medicine in February of this year. So they had looked at long-term follow-up of these 8 lupus patients, and again, all of them were in remission with their disease activity. The myositis patients also had normalization of their muscle inflammation, and the scleroderma patients had significant improvement in their skin thickening scores. So at this time, though, it still remains a lot to be investigated in terms of the role of CAR T cell therapies. So, of course, determining how long the CAR T cell response lasts for. Right now, the patients have been studied for up to 30 months, but will it still be working at 5 years or 10 years? We don't know. And at that point, would they potentially need retreatment? That also remains to be answered. We are still unclear as to the optimal B cell target antigen, since all of the CAR T cell therapies so far have been targeting CD19. And of course, there are also longer-term side effects that we need to be aware of and watching out for. So there has been a malignancy risk identified in people who have gotten CAR T cell therapy. So 22 cases of T cell cancers have been found so far, although 27,000 doses of CAR T product has been administered in the US to date. So that's an incidence rate of about 0.08%. But nevertheless, it is a risk, and that needs to be further characterized. And what about the costs? So in the US, the cost of CAR T therapy is estimated to be around $300,000 to $500,000 US per patient per infusion. And so that includes the cost of manufacturing the T cells, and the hospital admission, which usually is required for 10 to 14 days after the infusion, as well as possible complications and possibly needing ICU admission, and of course, long-term patient follow-up as well. So there are substantial costs associated with this therapy. However, there have also been studies looking at what the cost of lupus, and there was a Canadian study published by Dr. Barber in 2018 that looked at healthcare costs of lupus patients depending on the degree of renal dysfunction. So for patients who did not have any lupus nephritis, the 10-year costs were around $20,000 Canadian. For those who had lupus nephritis and a renal function GFR less than 30, the 10-year cost rose substantially to $310,000. And for those who had advanced renal disease, that 10-year cost was $450,000. So of course, there are also substantial costs associated with caring for lupus patients in general. And so when you think about these longer term costs in comparison to a one-time upfront cost for CAR T-cell therapy, they may not be so dissimilar after all. And what are things like currently in Canada and in North America? So there are actually dozens of active CAR T trials being conducted specifically for autoimmune disease, mainly in lupus, across the US and Europe and China. Before, CAR T therapy for cancer patients was only funded in Ontario, Quebec, and more recently, Alberta, Manitoba. So patients in BC actually had to travel out of province or even out of country to receive CAR T-cell therapy. But now, as of March 2024, BC is now offering in-province CAR T-cell treatment for cancer patients. And so for this first year, there's funding for about 25 patients. And there's a lot of academic research centers in Canada, like Accelerate or the Canadian-led Immunotherapies in Cancer and the Dealey Research Center, that are creating Canadian-made CAR T therapies that will hopefully allow for manufacturing decentralization away from the states and lowering costs. And in fact, the lupus group in BC is looking at collaborating with our local hematologists, as well as creating a national cohort of patients with autoimmune disease across Canada and in research academic centers. And there are also possible partnerships with pharmaceutical companies happening, although all of that is still in early stages. But it's very promising that hopefully some of these, that this CAR T treatment may become a possible therapeutic option for some of our lupus patients. And we hope that you will also be able to help advocate for this to come to us locally. So overall, in conclusion, we know that CD19 CAR T therapy seems to be highly effective so far in these limited patients that have been studied with lupus and myositis and scleroderma. Overall, the side effects have been relatively mild in comparison to hematologic malignancy patients. And overall, the responses seen have been dramatic, with even remission of disease without any medications. And of course, this does seem to be more effective than our conventional treatments. But at this point, long-term efficacy, as well as side effects, and of course, larger patient numbers will still need to be explored. But this is a very promising therapy that we hope will potentially offer in not only remission, but maybe even a cure for lupus patients within our lifetime. Thank you so much for listening.